a warm welcome to you all. My name is Nicola Bedlington, and I'm FH Europe's Senior Policy Advisor, and I have the honour and pleasure of moderating today's important webinar, the first of three, which we've prepared for our community with highlights from the European Atherosclerosis Congress, which took place last month in May in Mannheim. The focus of today's session are some of the latest research outcomes from the EAS FHSC, also known as the Global FH Registry, with which FH Europe has a long-standing partnership. We've covered in the past extensively the objectives of the registry and its design, and if you'd like to learn a little bit more about it, I would warmly invite you to visit the EAS FHSC website to watch previous recordings. We'll put those links on the chat for you. We're delighted to have with us today 4 international experts and researchers in the EAS FH study collaboration. So please welcome Kanika Darmayat, apologies, who also sits on the FH Europe Policy Advisory Committee, Dr. Amani Eshobagi, Dr. Alexander Lyons, and Associate Professor Fotios Barkas. A quick word about FH Europe for those of you who are joining us for the first time. FH Europe is a network of currently 31 patient organisations across the wider Europe. As an international community, we are committed to advocating for and supporting people living with inherited disability medias like FH, HoFH, elevated LP-a, and FCS. And this session aims to raise awareness and enhance knowledge amongst our patient community internationally, lay public, but also strengthening our buoyant group of patient ambassadors in each of these lipid conditions. We'd love to know more about you, so please write in the chat who you are, where you're coming from, and what you hope to learn from this webinar. And we are delighted to have so many of you attending regularly these FH Europe events. We get fantastic feedback, and hopefully this one will be as successful as previous events too. A couple of housekeeping rules. First of all, the webinar will be recorded and will be available on demand through our YouTube channel, and you can watch it subtitled in your local language. And please disseminate it widely across your communities. Hopefully it will be also interesting for the people that you're working with, your peers. If you have any questions, please post them in the Q&A section, and please indicate which of the speakers you'd like to direct your questions by just adding their initials, and we'll get to the questions towards the end of the webinar. Please, can I ask you to avoid specific personal health-related questions in relation to records or treatments? So hopefully that's all clear to you. So without further ado, let's go to the first presentation from Kanika, who will share the latest data on FH in children and adolescents. And of course, this is a vital topic, particularly given the work that FH Europe's driving on screening and detection. So warm welcome to you, Kanika, and please, the floor is yours.
Thank you very much, Nicola. Just setting up my slides. I hope everybody can see my screen. And again, thank you, Nicola and Magda and FH Europe for this kind invitation to present my work. As Nicola mentioned, that was presented in Mannheim last month at the EAS Congress. So specifically, I will be focusing on heterozygous FH in children and adolescents. So the outline of this presentation will really look at the differences in FH detection, so screening and diagnosis by country income status. And for this part of the presentation, I'll be focusing specifically on individuals, so children and adolescents, not on therapy, lipid-lowering medication, or LLM for short. And then the second part of the presentation, I'll be specifically looking at how children and adolescents with FH in the registry are being treated, and are they reaching the recommended threshold goals for LDLC. So I want to begin by how I ended my late breaker talk last year at EAS in Milan. And I also presented this late breaker talk at the FH Europe webinar last year. around the same time. And really the main messages from this talk last year were that it was the largest analysis on children and adolescents with FH worldwide on over 11,800 children. And what we saw were that typically what are the classical diagnostic criteria for FH, so specifically corneal arcus and xanthoma, these physical signs are actually rare in children and adolescents on a global scale. And what we saw, the next assessment that we saw was that when we looked at specifically the LDLC levels, we actually saw that this varies considerably by clinical criteria. So this effectively means that if clinical criteria is being used for diagnosis, there is a potential for missing children and adolescents with FH that don't meet the cutoffs that these clinical criteria sort of advocate for. So what we then next did for this work was we looked at percentile curves, and we actually saw that by each year of age, across both genders, so boys and girls, we actually saw that there is a clear difference in LDLC levels, even at the 5th percentile between those with and without FH. So that really provides potential, specifically at early age in life, to really, just by measuring LDLC levels, that we can potentially identify those with FH. So we know that FH is a global disorder and less than 10% have been identified. So to really kind of understand the wider aspects of why FH is being unidentified or at such a low identification rate, it really becomes important beyond the overall sort of analysis that has been done focusing specifically on the clinical outcomes and such, to really consider the wider determinants, so the social and economical outcomes, so broadly the income level and how these outcomes of a country can impact screening, diagnosis and treatment of FH in children and adolescents. So the objective for this first part of the analysis, or the first part of this presentation, was really to understand the current unmet need across the FH diagnostic pathway. So again, focusing on screening and diagnosis by country income status within the FHSC registry. And to do this, we used the World Bank 2023 country income status classification to look at what ages are children and adolescents being identified and how are they being identified. So for this specific analysis, we had data from 48 countries, of which over 11,800 were less than 18 years with a diagnosis of heterozygous FH. And what we see from here in this first set of results, when we look at the world map to the right-hand side of your screen, the green represents non-high income regions and the blue represents high income regions. And what we actually see is that within our data set, majority of the data is coming from high income regions. And when we next look at the way that the children and adolescents within our registry are being detected, we can actually see, if we look at the table on the left-hand side, now we're focusing on specifically non-high income countries versus high income countries. The representation of girls and boys is an equal representation by both genders within non-high income countries and high income countries. But where we start to see some slight differences are at age at which the children and adolescents are being entered into the registry. So specifically just about 2-year difference between high income and non-high income countries. Now, if we move to the right-hand side of your screen, specifically the bar graph looking at the percentage of genetic tests, we can actually see that compared to the high income countries, only 48% of children and adolescents underwent genetic testing in non-high income countries. So this effectively means that in non-high income regions, there's going to be a reliance and utilization of clinical criteria to help in diagnosing FH. And we saw earlier that that can potentially lead to misdiagnosis. And if we move back to the table, what we can actually see is that between the two different country income classifications, there's roughly a 7-time increase in the presence of corneal arcus and xanthoma, so the classical diagnostic hallmarks of FH. There's a 7 times increase in the presence of these physical signs in non-high income regions compared to high income regions. And we see a similar observation for coronary artery disease. So this effectively is telling us on some level that with utilizing clinical criteria, we're only going to be identifying children and adolescents that present with these physical signs and potentially coronary artery disease, and effectively missing children with who don't present with these signs and potentially have FH. So if we now look at specifically If we now specifically look at those children not on lipid-lowering medication and those on lipid-lowering medication, and again, categorized by non-high income and high income regions, we can actually see that there is a clear difference in LDL-C levels between those children and adolescents in non-high income versus high income countries. But then when treatment is initiated, we see that the LDL-C levels become comparable. So if we focus specifically on those children and adolescents not on lipid-lowering medication and consider the EAS guideline of severe hypercholesterolemia, which is more than 300 milligrams per deciliter. So if we look at the proportion of children and adolescents by country income status that meet this severe hypercholesterolemia criteria, we actually see that when we look at an odds ratio, there's a 360% increase of children and adolescents having this level of LDL-C level in non-high income compared to high income. So again, this iterates that, well, from the previous aforementioned findings, that if we're going to be using clinical criteria as is shown in non-high income regions, there's going to be a reliance of finding children with a severe or a severe phenotypic presentation of FH. So in conclusion, for this first part of the presentation, we saw that majority of the data comes from high income countries. And when we are actually finding children in non-high income countries, there's reliance or utilization on clinical diagnostic criteria, which potentially means there's going to be misdiagnosis or not identifying children and adolescents who don't have a severe phenotypic presentation, i.e. physical signs, coronary artery disease, and high LDL-C levels. So the next part, or the final part of my presentation, I'm going to be focusing on the children and adolescents within the registry that are on lipid-lowering medication. But I would like to say that I would be grouping them together and not categorizing them by non-high income and high income regions going further in this presentation. So we can see again from the slide that over 11,800 children had heterozygous FH diagnosis, of which just over 3,000 were on lipid-lowering medication. And if we look at the table on the left-hand side, we can see that the percentage of patients receiving lipid-lowering medication, or LLM, by sex and age at registry entry. And we can see by girls, there's an equal representation of both boys and girls on lipid-lowering medication. And unsurprisingly, as the age categories increase, so does the proportion of or percentage of children and adolescents on lipid-lowering medication. And if we focus specifically on the graph on the right-hand side, where we see on the x-axis different recommended LDL-C thresholds that are recommended to be achieved for individuals with FH. And we've again looked at the attainment of these different LDL-C levels by both the overall cohort and by boys and girls. And we can see across these different thresholds, there's a low percentage of girls reaching these different LDL-C thresholds across the different recommendations, but this is most pronounced in the 130 milligrams per deciliter category. So if we focus specifically on the children and adolescents who are attaining less than 130 milligrams per deciliter category, what we actually see is that when we compare boys and girls, there's a 26% lower odds of girls reaching LDL-C levels. So this effectively means that when both boys and girls are started on therapy, there's a lower odds or a low percentage of girls reaching these different LDL-C recommended thresholds compared to boys. And this was statistically significant. And whilst we saw no major differences in the other categories by age and country income status, if we move to the right-hand side of the slides, we can actually see when we compare monotherapy, so just on one type of medication versus combination therapy, so more than one or two types of medication, we actually see that when two therapies are initiated, there is specifically an 83% increase in attaining this LDL-C level of 130 milligrams per deciliter, compared to just being on one type of medication or no type of medication. So again, this is highlighting that children and adolescents are perhaps needing multiple medications in order to achieve different LDL-C thresholds. So finally, I would just like to acknowledge all the EAS FHSC collaborators and investigators who have contributed to this registry network, of which this analysis that I have presented to you would not be possible. So thank you for listening.
Thank you so much, Kanika. That was a fantastic presentation, as always, and once again reinforcing some of the fundamental inequalities and this phrase missing children. I think, yeah, that's something that we are all tremendously concerned about also in the FH Europe community. I'd now like to hand over to Amani. A warm welcome to you. It's wonderful to have you with us. Your research is dedicated to the global prevalence of overweight and obesity among children and adults with FH, an association with CVD. Please, the floor is yours. We look forward to your presentation.
Hello, everyone. Hello, Nicola, and thanks very much for the introduction, and thanks to FH Europe for this opportunity to share our research with the wider sort of patient and doctor community. So I'm a cardiovascular epidemiologist at Imperial College, and I have the privilege of working with this phenomenal global registry data set where 70 countries, as you know, have come together so far to try and sort of understand the determinants of better health in people with FH. So everyone knows that overweight and obesity are not good for you. We know this for the general population. If you look at, let me try and minimize this. So if you look at, so this is data from the general population where, you know, that all that green tells you that 50 to 70% of people in these countries in the general population are overweight and obese. So it is really probably the only disease where you have, you know, more people with the condition worldwide than without the condition. So very prevalent, and it is bad for your heart. So we know that, hang on, I'm just trying to shift there. Okay, yeah, so you know that we know that in the general population, people who are overweight have a 20% higher risk of coronary artery disease, and people who are obese have a 60% higher risk. So we basically asked the question of, you know, people with FH, they are already at increased risk of coronary artery disease due to their high LDL cholesterol, but does their body weight matter? So how common is obesity in these individuals? And does it add to their CVD risk, or is it all about LDL cholesterol? And we really started on this analysis not knowing what we would find. So looking at the registry, we had data from 51 countries who had provided body mass index data from their patients. So body mass index is basically your weight divided by height squared, and it's sort of an index of obesity. So we had about 29,000 adult heterozygotes and 6,000 children heterozygotes, and smaller numbers of homozygous individuals. And the way we split them into normal weight, overweight, and obese is pretty standard. And so it was following WHO guidelines. So in adults, you have cutoffs. So if you're like between 18.5 to 25, that's perfect. Above that, until 30, that is overweight, and over 30, that is obese. And in a similar fashion, the WHO has cutoffs for children, so you're able to categorize them. So we basically looked at, okay, what percentages do we have across this FH population? And so this is what we found. So the red here is people with obesity, and the orange is people with overweight. So collectively, you are looking at, and these are cumulative percentages, so you are looking in the adult heterozygotes at 52% overweight or obese, and similar in the adult homozygotes. Whereas in children, you are looking at 27% and 25% overweight or obese in the heterozygotes and homozygotes. So a very prevalent condition in people with FH. We then had a look at, as Kanika did with her data, to look at high income versus non-high income countries. And you can see here that in adults, you've got a slightly bigger percentage of overweight and obese in the non-high income countries than in the high income countries. It's not really obvious in children, but then the numbers are actually quite small. But it does seem to be more of a problem in non-high income countries than in high income countries. We then split by UN region, and looking at all the different world regions where we had data, and you can see that the percentage of overweight and obese ranges from as low as 27% to 82%, depending on the various world regions. So there was a wide sort of variability, as you would expect, across the world regions. So this is a prevalent condition. We then asked the question of, okay, does it influence the likelihood of having coronary artery disease? And so we just plotted the percentages of people. We pooled the sort of the underweight with the normal weight in here. And we plotted the percentages of people who had coronary artery disease at the date in which they were entered into the FHSC registry. So I want you to note here the very different scales on the y-axis. And this is what you would expect, right? So in children, you've got, a very low percentage of children will have coronary artery disease at registry entry, whereas the highest percentages you see with patients with homozygous FH, where already 1 in 3 people, even with normal weight at registry entry, has coronary artery disease. So emphasizing that this is just cross-sectional data. So these are not people that we followed up until they developed heart disease. No, this is data at registry entry. So the body weight and the coronary artery disease are measured or evaluated at the same time. But here you see that, in children, even though if you look at the normal weight children, only 0.1% of children have heart disease at registry entry, but it is multiplied massively. You've got a 7-fold likelihood of having heart disease in children who are obese. With adults, you are looking at a 3-fold likelihood. So you go up from 10% to 30% and, a graded response. So with the overweight being somewhere in between. In homozygous patients, you're looking at 30% if people are normal weight or overweight, but nearly 50% if people are obese. So even in homozygous FH, where, massively high LDL cholesterol levels drive the risk, obesity is an important factor to consider. But then we wondered, is obesity acting via making the lipid profile worse? Or is it sort of acting independent of those factors? So to try and tease this, we looked at how body mass index influences plasma lipids. And in our analysis, we controlled for age and sex and lipid-lowering medication, which are the major determinants of people's plasma lipids. So even after you've adjusted for these factors, if you look in adults, if you look at across the BMI range, so this bit is the sort of normal weight range, and then to the right of the yellow line, you've got the overweight, and then beyond the red line, you've got the obese range. And you see that the mean LDL cholesterol just goes up, both in children and in adults. And the HDL cholesterol, the protective element, goes down with increasing body mass index. And the remnant cholesterol, which is the triglyceride-rich sort of atherogenic component, also goes up with increasing body mass index. So obesity appears to be associated with a higher prevalence of CVD and a worse lipid profile. So we tried to then test how sort of tease these factors apart. So we looked at the likelihood of having coronary artery disease by body mass index after you control for the plasma lipids. So is it all plasma lipids, or is obesity doing something else? So here is a model of a model trying to predict the likelihood of having coronary artery disease. So if you look at this dotted line, so this is like your reference group, which is the normal weight group. And these will always have an odds ratio of 1. Compared to this group, you have the overweight group, who sort of in the different models, we control for different factors. So you see in this fully adjusted model, you've controlled for age, sex, lipid-lowering medication, plasma lipids, even diabetes, hypertension, smoking, factors that are sort of traditional risk factors for heart disease. And you are looking at 40 to 50% higher odds, and highly significant, of having heart disease if a person is overweight versus normal weight, and much higher if the person is obese versus normal weight. So you're looking at 2 to 2.5%, 2 to 2.5-fold higher likelihood of having heart disease, even when you control for all the subject characteristics that could be influencing the risk. So to summarize these data, we found that globally, across the global FHSC registry, 1 in 2 adults and 1 in 4 children with FH are overweight or obese, and that obesity in both children and adults is associated with a worse lipid profile, regardless of whether they are on lipid-lowering medication. And that obesity, at least in heterozygous FH, is associated with coronary artery disease independent of lipid-lowering medication and independent of their LDL cholesterol. So as far as you can get conclusions from cross-sectional data, now, we haven't gotten a group of people and followed their body weight and subjected them to weight loss and looked at whether risk changes. So we have to be cautious with interpretation, but our data strongly suggests that together with lipid-lowering medication, weight management would greatly increase, sort of improve cardiovascular outcomes in people with FH. And with this, I'd like to thank all the investigators who've contributed data to this analysis, and to thank you very much for your attention. Thank you.
Thank you, Amani. Again, a very, very clear presentation looking at the significant impact of overweight and obesity in relation to people living with lipid conditions and FH specifically. Let's move on now to Alex, who will, to a certain degree, build on Amani's findings and focus specifically on diabetes. A warm welcome to you, Alex. You'll tell us a bit more about the association between BMI, lipid-lowering medications, statins specifically, and age with the prevalence of diabetes in adults with FH. Please, the floor is yours.
Thank you, Nicola. Okay, so hi everyone, my name is Alex. I'm a research associate and project manager at Imperial. And like my team members giving talks today, we all gave these talks at the EAS Congress in Germany. And as we come to the end of our grand tour, we're happy to give the talk with you good people. It's very important to reach out on a patient level. So the study that I was working on, or am working on, is looking at the association between body mass index, lipid-lowering medication, mainly statins, and age with the prevalence of diabetes in adults with the more common type of FH. So what I'm really asking is, could carrying a few extra kilos of body weight impact the likelihood of diabetes when undergoing treatment for FH with age? And the justification for this study is that data on diabetes in the FH population is lacking in most world regions, with no global study published to date, but we're working on it, so stay tuned. There are, however, national level studies that reported fewer cases of diabetes in the FH population, but could this change when BMI increases, given the ethnic diversity between different countries? Also, it's important to note that, statins are beneficial to reduce the risk of atherosclerotic cardiovascular disease. However, it does have a possible impact on type 2 diabetes. So that moves me on to my disclaimer. This study is not advocating a revision of treatment whatsoever. Treatment to lower the high LDL cholesterol in FH patients must continue, or in many cases even be initiated. If you would have read our Lancet paper from 2021, we showed that FH is commonly underdiagnosed and undertreated. Anyhow, in the present study, firstly, we looked at the prevalence of type 2 diabetes globally. So drawing your attention to the bars on the left-hand side, as we can see, it's like a traffic light system going from normal weight to obese. Those obese had, the prevalence of type 2 diabetes was much greater in those with obesity than those without, with a similar pattern of normal weight versus being overweight. And epidemiologists love to categorize by different regions. So we have chosen the WHO world regions. Reason being, to my understanding, each WHO region has its own office that governs clinical policy on a regional level. So if we look at globally and regionally, the information we give might be more accessible. So within the WHO regions, the greatest prevalence of type 2 diabetes was in the Eastern Mediterranean at 45.1%. And how does this compare to the general population? So this table was taken from the International Diabetes Atlas. And we can see that the greatest prevalence of diabetes is in the MENA region. And when we look at the MENA region on the map, it's quite literally the same as the WHO region of the Eastern Mediterranean. So the regions are comparable and the results are relatively consistent. So that moves us on to what are the chances of having diabetes in the FH population based on the given variables. So here we're looking at the relative risk. Let me draw your attention to the data points in the blue circle. So these are the lowest risk groups. Whether or not they're on lipid-lowering medication is irrelevant. You can see the variation isn't that great. But mainly those that are younger and without obesity have the lowest risk of developing type 2 diabetes with FH. And when we look at the higher risk groups, the data points highlighted in the green circle, we can see that the risk has substantially increased compared to those, the low risk group. So older age group, those that are obese have a 43 times more likely to have diabetes than the low risk group. However, when you remove obesity in this older age group, and then the chances falls to 17, or the odds falls to 17 times more likely. So the clinical messages are very simple and clear. Firstly, the relatively low prevalence reported in prior studies, particularly on the European cohorts, may not be generalizable to other demographics, since our study showed that the prevalence was greater in different regions given its ethnic diversity. And of the independent and modifiable factors associated with the risk of having diabetes, obesity management is key. So clinicians must encourage and guide their patients to reduce obesity or prevent obesity to mitigate risk. This is, however, a cross-sectional study, which means it's a snapshot of data taken at any given time. So further work would be needed to follow up the patients and compare them from baseline. So that's the next study in progress. Many investigators contributed to this study, so we acknowledge all FHSC investigators and thank you for your time.
Thank you, Alex, and you've whet our appetite for some research upcoming to delve further into detail here, but clearly the association between obesity and diabetes in people living with FH is clear. It would be great to get a few more questions as we go through the presentations or reflect on the ones that have already been delivered. So please, participants, think about anything you'd like to ask our excellent presenters. So our last speaker now, a warm welcome to Photios. This topic is especially close to my heart as I'm leading a project developing a global policy strategy and roadmap in the area of Lp(a) on behalf of FH Europe. We're at the starting point of that, but it's a really exciting initiative. So Photios, please share learnings from the registry regarding lipoprotein (a), known as Lp(a), and ASCVD in adults with FH. Please, the floor is yours.
Thank you, Nicola. Thank you, FH Europe. Thank you, Magda, for this kind invitation to join this very interesting webinar. I would like to underline that I'm a physician in internal medicine, working in one of the largest lipid clinics in Greece. And I consider myself very lucky to join the FHSC team recently. And this is why I'm going to present to you on behalf of FHSC registry our work on the association between lipoprotein(a) and cardiovascular disease in adults with heterozygous familial hypercholesterolemia. So what we already know is that LPL-A is actually a small LDL particle that assembles LDL, and we know for sure now that there's a causal continuous association between LPL-A and cardiovascular disease, as well as this is a new risk factor for aortic valve stenosis. Actually, elevated LPL-A is the most common monogenetic lipid disorder that is associated with increased premature cardiovascular disease, and it is very frequent in the general population. Almost 20% of the general population is estimated to have high LPL-A levels. So this is why LPL-A should be measured at least once in every adult. And until we have effective LPL-A lowering therapies, we need to optimize the control of other cardiovascular risk factors in these adults. So we know that there is a connection between FH and LPL-A, but these two diseases are quite different in terms of their pathophysiology. On the one hand, FH is the inherited condition that is caused by mutations that are involved in the catabolism of LDL particles. On the other hand, about 90% of the LPL-A levels is determined by a single gene, the LPA gene. So we don't know for the moment why this happens, why FH individuals usually have high LPL-A levels. This might happen due to the fact that there's a high probability that most FH individuals might have been misdiagnosed due to the high LPL-A levels. But regardless of this association, the joint combination undoubtedly increases the increased cardiovascular disease risk in these two conditions. But most data derives from individual studies, small studies in specific countries, and this is why we need data from a global registry like the FHSC registry. So our primary aim was to investigate the global distribution of LPL-A levels and its association with atherosclerotic cardiovascular disease in adults with HeFH. So this is a cross-sectional analysis of adults from the FHSC registry, and the inclusion criteria was first a clinical or genetic diagnosis of HeFH, and of course we included those individuals who had available data on LPL-A. We excluded the individuals who had very high untreated LDL cholesterol levels due to the high probability of them being homozygous, and we investigated the association of LPL-A with atherosclerotic cardiovascular disease presence upon the time that these individuals entered our registry, after of course adjusting for a few certain traditional cardiovascular risk factors and their concomitant lipid lower treatment. So as you can see here, among the 70,000 individuals that were initially enrolled in the FHSC registry, we finally included almost 3,000 HeFH adults in the present analysis. Among them, almost half of those were females. Their median age was 48 years old. The majority of them were diagnosed genetically, and the majority of them also fulfilled the DLCN criteria for a definite FH diagnosis. In terms of where these individuals lived, because we had limited data on their ethnicities, we have to state that most of those participants lived in Europe, followed by America, Asia, and Oceania at the last position. So what happens with the distribution of LPL-A in this population? So in terms of the median LPL-A levels, we found out that the median were 23 milligram per deciliter, which is twofold higher than that of the general population. Similar findings were noted regarding the LPL-A percentiles, which were higher than those of the general population. And when we search for the proposed cutoff in the general population, which are 30 and 50 milligram per deciliter, we found out that almost 13% of these individuals had their LPLA ranging between 30 and 50 milligram per deciliter, and almost 30% of FH individuals had higher LPLA levels than 50 milligram per deciliter. There was no difference between males and females, men and women, I mean. And afterwards, we investigated the LPLA distribution across different UN regions because, once again, we didn't have any data on their ethnicity. So we found out that the individuals who lived in Eastern Asia, meaning China and Japan, had the lowest LPLA levels compared with the rest people who lived in other countries, which is in line with the data that we know from the general population. So what happens in terms of the presence of atherosclerotic cardiovascular disease? So we found out that LPLA is continuously and significantly associated with the presence of coronary artery disease, but no difference were noted regarding stroke and peripheral artery disease, as you can see here. This was not significant, but this could be attributed to the fact that we had extremely low prevalence of stroke and peripheral artery disease in our study sample. So afterwards, we stratified the sample based on the tertiles. So we divide them into three categories: those having lower LPLA levels than 12 milligram per deciliter, those having between 12 and 42 milligram per deciliter, and those having higher LPLA levels than 42 milligram per deciliter. So we found out that in comparison with the lowest LPLA tertile, those being in the second tertile, had a higher odds by 50% for the presence of coronary artery disease, and those having those belonging in the highest LPLA tertile had a twofold higher odds for the presence of coronary artery disease. And the interesting point was the fact that this association remained significant, especially for the highest LPLA tertile, and independent of the gender, of the age, of the kind of FH diagnosis, smoking, hypertension, diabetes, BMI, lipid levels, and concomitant lipid lowering medication. Of course, our results have a few limitations. The present study is a cross-sectional one, so our results might have been biased by the fact that FH individuals who have many other additional cardiovascular risk factors, such as elevated LPLA, might have been more easily to a lipid clinic because due to these factors, they might have been diagnosed with a coronary artery disease event. So we need follow-up data in order to confirm this association. There were a minority, of course, not the majority, but there was a minority of FH participants who were clinically diagnosed. So a few of them might have been misdiagnosed due to high LPLA levels. We don't have any data on the measurement technique of LPLA. Once again, we had limited data on ethnicity, and unfortunately, non-European countries were underrepresented in our sample. So we need more of you to search for any lead investigator in your country, or maybe push your country to join the FHSC registry in order to have more data from other countries apart from Europe. So which are the main conclusions of the present analysis? Almost 1 in 3 FH adults with HeFH have higher LPLA levels than 50 milligram per deciliter. That means that actually over 8 million HeFH individuals might have at this moment high LPLA. And what does it mean? More coronary artery disease events and more deaths. And this is why we need maybe the implementation of new health policies. For instance, maybe we could screen for LPLA globally or in certain countries, or new registries in order to identify the global burden of elevated LPLA levels. And of course, in addition to optimal LDL cholesterol control, we need effective Lp(a) lowering therapies in order to further reduce the risk of coronary artery disease in individuals with FH and high Lp(a) levels. So at this point, I would like to thank you for your attention. I'm very pleased to answer any questions of yours. And afterwards, if I may, of course, if I may ask you, if you want to answer certain questions for your part based on our data. So thank you for your attention.
Thank you so much, Matthias, and also for that clear call to action that Magda's reinforced in the chat. So think about how we can mobilize in non-European countries. That's really, really important. I think there's a actual specific question for you in the Q&A, Amani. So let's go first of all to that one. Would you like to respond? Maybe repeat the question as well, please.
Yes, hello. So the question asks what type of coronary artery disease in children and how is it determined? Yeah, that's a very valid question. So for both children and adults in the registry, we have a comprehensive data dictionary that we share with the national lead investigators. And coronary artery disease, in this context, it refers to clinically manifest coronary artery disease. So things like starting from angina, myocardial infarction, as diagnosed by the treating physician.
Super, thank you very much. Good. A question that I'd like to pose to Kanika is, let me just find out where we are. How can the data on children and adolescents from the FHSC, from the global registry, be used for policy and advocacy? And of course, you're not surprised to get a question like that from the FH Europe and our community, given all of the policy work we're trying to drive. But I'd love to see what your thoughts are in that domain.
Absolutely, Nicola. Thank you for the question. I think what we have seen from the two types of analyses that I've done, from sort of a very overall analysis and then focusing on the specific subgroups, we're seeing that actually children are not the focus of any types of screening strategies. They're usually being identified following their parent being found, either due to that parent having a cardiovascular event or there being some screening strategy in certain countries. And we know that the earlier you identify, the earlier you can intervene, and then you can potentially change the prognosis of the life course of those individuals. So it becomes important to identify early so we can treat early. And as we have seen, and as I mentioned, that if children are not the focus, that means we're not going to be identifying them early. So it becomes important to do some kind of universal screening based on, health system availability of resources and things to really try and find FH and early in life, which is childhood, which then potentially has implications on the parents as well, because you can potentially, if you identify in childhood, you can potentially identify FH in the adults and the parents before they actually have an event. So I think there's a multi-pronged impact really towards the policy advocacy for that.
Fantastic, great. Let's go back to Photius, again, focusing on Lp(a). Is high Lp(a) or elevated Lp(a) more prevalent in people with FH, or is it simply that Lp(a) is so common that we also see it in FH, or is it hard to say because of insufficient data?
Thanks for the question, Nicola. It seems that for the moment we don't have sufficient data to support this, because we need a sample from the general population in order to compare these two quite different populations. But yeah, we know from other studies that FH individuals would usually have high Lp(a) levels, but that this might happen due to the high probability of them being misdiagnosed, because we know for sure, for instance, that FH mutations have no relation with the Lp(a) levels. And so we're expecting for new data from our registry in order to confirm this theory that indeed there is no difference in FH individuals and non-FH individuals in terms of Lp(a). But yes, I agree with you that Lp(a) is quite common, much more common than FH prevalence. Yeah, so we need global action to identify also these individuals.
Exactly, and of course, the consensus guidelines talk about testing once in a lifetime, and that's definitely the policy thrust that we would like to take in an FH Europe environment. Let's jump to Alex now. Statin treatments seem to be associated with higher diabetes prevalence. Do we know why?
Well, it's been postulated that taking lipid-lowering medication will increase or may increase pancreatic lipotoxicity. So where the cholesterol accumulates in the blood, if you remove it from the blood and get a greater cellular uptake in beta cells within the pancreas, and then that could be a factor. But that's only been proven in a couple of studies on mouse models in terms of the mechanism. But in wider meta-analyses on clinical trials, it has been shown that the incidence of diabetes is greater in those on the medication. However, it must be noted that the benefit of taking statins to reduce the risk of atherosclerotic cardiovascular disease outweighs the risk of diabetes.
Okay, super. Very clear message there. Thank you. Back to Amani. Do we know if obesity similarly influences the likelihood of stroke in people living with FH?
Thanks, Nicola. Yes, so we didn't have many stroke events in children, but we had a look in the adult data set. And at least in the adult patients with heterozygous FH, you also see an increased likelihood of having had a stroke event if the person is overweight or obese at registry entry. So it does seem to be associated with stroke incidence, at least as far as we can see in adults with heterozygous FH.
Thank you. Thank you for that. Let's jump then back to Kanika. Do we know the factors influencing differences in treatment between boys and girls? You talked about that a little, but it would be great if you could revisit that.
Yeah, no, thank you. Yes, it was an interesting finding, but somewhat unsurprising as well, because we see that even within the adults that we've looked at in the FHSC registry, that there is actually a difference in attainment of recommended thresholds between men and women, and seeing that same trend in boys and girls is interesting, whilst also unsurprising. And I think mostly because we see historically that there is, based on past studies, that there is some sort of apprehension or trepidation to providing or prescribing medication to girls because of the potential impact that it may have on puberty, etc. And whilst it has been kind of shown that actually it doesn't have any effect, perhaps there is still these sort of apprehensions. And I think that's the next part of our phase of our study. We'd really like to assess and explore what could be the potential factors that could be influencing treatment patterns and prescription patterns. And because I think that would be really informative to try and change the way that both boys and girls are being treated.
Fantastic. So that's sort of in the planning. Great. Good to know. Let's jump back to Fotis again, thinking about Lp(a). Based on the registry, can you observe the uptake of tests? And is there any best-in-class country, or any countries where it's really not yet recorded? What's your perspective on that?
Unfortunately, these are the caveats of registry with patients. Unfortunately, we can do such an analysis because, first of all, you have the present analysis was based on data entered a few years ago, long before the recommendation that every adult should measure their LPA. So we don't have any clear idea what actually happened in every country. So yeah, we might have seen a trend in certain countries, mostly in Europe, to measure Lp(a), but on the contrary, for instance, we have no country from Africa with available Lp(a, that it doesn't mean anything. We hope that we will have follow-up data in the future from all of these countries in order to have a clear idea what happens with Lp(a) measurement, and if there's any trend of difference between these countries.
Okay, very good. We've had another question come in. We've got about 1 minute to answer it. So it again to you, Fotis. For determination of elevated Lp(a), what percentile cutoff level would be most appropriate? Can you do that very briefly?
Yeah, of course. Actually, we don't use now a cutoff regarding Lp(a). We usually use the cutoff, the 90th percentile, but now we know for sure that there is a continuous linear relationship between Lp(a) with atherosclerotic cardiovascular disease. So for the moment, we cannot propose a specific cutoff for Lp(a) in FH individuals. Okay,
thank you very much for answering that briefly and succinctly. Great. So this hour has passed really quickly. And as we come to the end of the session, allow me to thank warmly all our excellent speakers for sharing their work in a really accessible and relevant way for our community. And thanks to you, the audience, for really bringing your time, your attention, your engagement to this really critical topic. We need to understand what's happening in the registry to be able to move forward on some of our vital work as well. Before finishing, let me remind you about 2 further webinars coming up soon. The first one will focus on highlights from the Pediatric Symposium at EAS, and the second one on the latest science in the lipid space. So you'll be hearing more from us about dates and times of these next webinars. So thank you all from my side once again. I've learned enormous amounts, and I hope that you have too. Thank you and goodbye.
Thank you.